Okay, so I'm doing task 6, which is monitoring with an anesthetic monitoring chart, or our discussion on physiological status related to patient reflexes to the depth of anesthesia. So, we want to make sure that when a patient's under anesthesia that, of course, that they have the correct amount of immobility, muscle relaxation, pain relief, and central nervous system depression that we can properly be able to do our procedure, but in doing so, we're also, of course, affecting that patient's physiological status with their cardiopulmonary system. So we want to make sure that, when we put a patient under anesthesia, that we're monitoring them correctly, heart rate, respiratory rate, etc., that we aren't affecting their body system so that they will wake up okay, but also that they're not going to feel it, not going to remember the surgery, and wake up smoothly like nothing's happened to them. So we have a very delicate balance that we have to keep together. So starting off with the physiological statuses, heart rate. So of course we want them to have a regular heart rate. That lets us know how well they are getting circulation of blood throughout their body that's carrying oxygen. For dogs, that's going to be anywhere from 60 to 120 beats per minute. Cats anywhere from 120 to 180 beats per minute, depending on size and condition of the patient. But we just want to make sure that that stays normal throughout the procedure. You want to look out for those jumps in heart rate that can indicate pain potentially. Severe decrease is also obviously dangerous, and of course we also have the problem that a lot of the anesthetic drugs we use decrease heart rate. So then of course we move on to heart rhythm. So that would be something that our EKG is going to tell us. So our EKG leads here, to our monitor. This is what gives us that EKG reading, which gives us the wave that tells us about the electrical conductivity activity of the heart. So in dogs and cats, it's normal to have a normal sinus rhythm. So we want to make sure that they have that normal P wave with the QRS complex. So shutting it out. This would be the rhythm that you're looking for. You want to have nice, even wave forms. So obviously this would be something to look out for when you're reading that EKG, when you're monitoring that. The big thing you want to look out for is arrhythmias. Of course, in fit young dogs, sinus arrhythmias are pretty normal. As you can see here, there's gaps in the complexes. So now you have a couple of normal waves with a gap, a couple of normal waves, gap, etc. So you have to know when it's dangerous and when it's something that you need to alert the doctor about. Next, we have mucous membrane. So that is a sign of ventilation. So, on our patient, we would pull up the gum usually and look to see the color of their mucous membranes. Normally, you want those pink. Going pale is, of course, that they're not getting their poor tissue perfusion throughout the body. They're not getting a lot of blood flow. Of course, when it goes to cyanotic or purple or blue, that means they're getting very low oxygen rate. It's not the best indicator of ventilation because of the fact that when it goes pale or purple, you're already in an emergency situation at that point. Something you still want to look at, though. So next we have capillary refill time. So that lets you know about tissue perfusion as well. So what you would do is, press on that gum. That's going to block off those capillaries for blood. And then when you let off, that will refill. And so you count the seconds that takes. Normally it's about less than 2. So what you're looking for while they're under anesthesia, you want to make sure that they're adequately getting enough blood throughout their body, especially because they're probably losing blood too. So next we have pulse and blood pressure. Pulse is not something that's super commonly, something you want to check obviously, but it's not as accurate as checking blood pressure. Of course, check pulse by checking any of the peripheral arteries. You want to make sure, of course, that matches up with the heart rate as well. Blood pressure, we measure that either with the cuff and the sphygmomanometer or the Doppler. So Doppler, of course, you have to listen for that whooshing sound. and it's an ultrasonic probe. We have one, but it is put away because they're very expensive. Generally, back in our surgeries, we use our cuff though. Of course, this lets you know about tissue perfusion. So same thing, making sure that the body is getting adequate blood flow throughout. In patients, you want that to, the readings are going to be a systolic, diastolic, and a MAP, or the mean arterial pressure. So the main one that we look at, because it's going to give us the best reading, is going to be that mean. You want that to stay above 60. In a normal anesthetized patient, it's between 60 to 150 usually. So you want that to stay at least above 60. Since it's such a good indicator of tissue perfusion, you know that when you have to watch the kind of the trends with it to see where it's going. Because a lot of times when you start out, a lot of the anesthetic agents will decrease blood pressure. So you have to make sure that it is going up as you take the readings. So one of the main ways to bump that blood pressure up, of course, is to decrease anesthesia. Hypertension is commonly caused from too deep of an anesthetic depth, and increasing fluid rate. That way you're getting more fluid through the body, better tissue perfusion. Then, of course, we move on to respiratory rate. So that's going to let us know about circulation, that the patient's taking in enough oxygen. So you want to make sure that they're not hypoventilating. Commonly, you'll see the hyperventilating because they could be too light. Feeling the pain from when that surgeon puts a towel clamp on. It's commonly seen where they'll kind of jump a little and their heart rate will jump up. So you want to make sure that they're at the correct anesthetic depth. Same thing with hyperventilation. When they go too deep, their respiratory rate is going to drop. And same thing, a lot of the drugs decrease respiratory rate. Respiratory rhythm, same thing, you want to just make sure that it is, biggest thing with that, of course, is listening out. Your capnograph is going to, our capnograph at least, lets us know what the respiration rate is and tells us when there's no breaths. But of course, you can also, biggest thing is watching the patient and making sure that you're seeing their thorax move and their chest walls move. And watching the bag and watching the reservoir bag and watching the valves to make sure they're inspiring and expiring. Same thing as respiratory rate. That's going to let you know that they're taking in an adequate amount of oxygen. So for both cats and dogs, you want that respiratory rate and rhythm. You want about 80 to 20 beats per minute. Anything lower, of course, it's a big emergency. Anything higher, they're probably too light. So then body temperature, very important thing to watch out for, because if the body temperature drops too much, you're going to have, that patient's going to have a hard time waking up and coming around after anesthesia, because their body is not going to be able to metabolize the anesthetic agents out. And you're looking potentially at, if they can't metabolize it well enough, even while they're under anesthesia, you could give them liver, kidney damage kind of thing. So for dogs and cats, you want them to stay between 97 and 100 degrees Fahrenheit. That's why we use warming tables and warming circulating blankets, all that kind of thing on them, to make sure that they will recover from anesthesia better. Okay, so relating those reflexes and physical stimulus to how light or deep a patient is under anesthesia. So starting off with that ear flex reflex. So that would be doing, if the dog's ear is up, kind of inside, or squeezing the outside to elicit a response of some kind of flick. That's going to be present when they're under pretty light anesthesia. Something that can be useful when you're masking a patient down, and to try to wake them up, kind of irritating them, so they'll kind of flick their ear some. It is absent in deeper anesthetic depths. Then the pedal or withdrawal reflex, so that would be taking the paw and giving it a pretty good squeeze to elicit that jerk back. Same thing, going to be useful when you're masking a patient down. Only going to be evident during light anesthesia. Once they go deeper, it's going to be decreased. And it's not the best indicator when they're light because of spontaneous movement. So propofol can give spontaneous movement. Then moving on to the eyes, the palpebral or the blink reflex. So you would be touching on the medial or the lateral canthus of the eye, and just a little touch, looking to see if they have that blink. That's going to be obviously apparent when they're light and to some medium depths. Depending on how deep they are, they will have a little bit of a blink. So that's a pretty good indicator of depth. So then of course there's the laryngeal or swallow reflex. So when mainly you're going to see this when you're intubating the patient, is that, when you open the mouth and go down to intubate and touch any of those laryngeal folds, you're going to elicit a swallow. Cats, of course, it's a lot more apparent than dogs. It's a lot stronger. A lot of times you have to use lidocaine to numb those to intubate sometimes. Particularly useful when they're recovering from anesthesia, though. That lets you know when you're able to pull the endotracheal tube, that if they're swallowing okay, they're not going to be able to regurgitate. So that's when you can pull the tube. Jaw tone, pretty good for when you're inducing anesthesia. So of course that would just be opening the mouth, seeing how tight the jaw is, see whether you can intubate or not at that point. Obviously going to be lost at deeper anesthetic depths. Eye position, so that is a great indicator of anesthetic depth. So at a light plane, they're going to be central. As the deeper the patient goes, they're going to rotate ventromedially, so downwards. But then as they go even deeper, they'll come back central. So really want to make sure that you're watching for that while you're monitoring, to make sure that that patient hasn't all of a sudden slipped into a deeper plane and you're like, oh, well, they're central, they're actually really light, but no, they're very deep under anesthesia, which is not good. The last one's going to be respiratory pattern. So that's going to let you know if a patient is potentially feeling stimulus, such as the surgeon, making the incision, putting towel clamps on, etc. You'll see hyperventilation. And then, of course, the deeper they go, the more decreased the respiratory rates when they get. So something you want to watch out for to make sure that they're not going too deep and losing their respiratory rate. So we want to make sure that we are using those vital signs and those reflexes together to figure out how deep that patient is under anesthesia. Those vital signs are going to tell you about the patient's well-being, whether their body still functioning normally, you want a regular heart rate, respiratory rate, that their temp stays up, etc. Those reflexes are going to let you know how deep that patient actually is, which if they go too deep, you lose the body functions and well-being of the patient. So it's we want to make sure that we're monitoring all of those things together to be able to figure out how deep our patient is. So we start off with stage 1. That's going to be the of anesthesia. That's going to be that fear disoriented stage. Heart rate, respiratory rate are going to be increased. Stage 2, the excitement phase. Their respiratory rate will sometimes be irregular. It's going to be increased. Same with heart rate. Generally, if you're inducing a patient, you're not going to see those. They're going to pass directly from being sedated from their pre-med to stage 3 of anesthesia, plane 1. But if you're masking the patient down, you're going to see that struggle. When they pass through those stages to stage 3, though, you're going to be losing those pedal reflexes, their swallowing reflex. So those will be lost of you when you can intubate the patient. So when they move from that plane 1 to the plane 2, the surgical plane, that's when you're going to want to be very cautious because obviously that's a good anesthetic depth. Their respiratory rate is just going to probably be a little bit lower than normal. Respiratory rate should be normal to high normal. They're going to lose more of those reflexes though, like the laryngeal, the pedal, the palpebral probably. So it's a time that you're going to be wanting to be very careful about how you're monitoring everything, that painful stimuli that the doctor could be doing, such as clamping off or making an incision. You don't want the patient to be able to feel it, so you're going to have to increase that inhalant some, but at the same time you don't want it to be decreasing blood pressure or heart rate or respiratory rate and affecting the body functions. So it's a very, careful thing that you have to be doing when you're monitoring at that stage, because you want to keep them on that plane. The plane after that is going to be the deeper plane. The respirations are probably going to become a little shallow, heart rate's going to decrease. That's when the eyes would go from that central, they would be ventral and medial, they would come back into central, because at that point patient would be too deep. As I said, it's very careful thing. That's just one plane in a stage that you're looking at changing that eye position. They'll have lost all muscle tone, and then they'll travel in the stage plane 4, which is jerky. At that point, they start abdominally breathing, so they start their respirations very increased, and they're having a harder time moving oxygen throughout their body. And then they'll move into stage 4, which is that moribund stage, which is when they're pretty close to death. They'll have apnea. Their cardiovascular system will basically have collapsed at that point. So very cautious thing that you have to be doing with patients, with monitoring and correlating all those vital signs with those reflexes.